This literature review will be covering the article titled Prevalence of Obesity and Extreme Obesity in Children Aged 3 to 5 Years. My name is Luke Vazzano, and I'm a master's candidate in nutrition at NC State University. Again, this presentation will review the article Prevalence of Obesity and Extreme Obesity in Children Aged 3 to 5 Years. The article authors and DOI can be found on the slide. We will first discuss some background information on the topic before getting into the heart of this article. Obesity is defined as body mass index, BMI, at or above the 95th percentile. In the US, there are currently 12 million children aged 2 to 19 years that fit this definition. In addition to regular obesity, there is a growing spectrum of severe obesity, previously classified using a threshold of BMI greater than or equal to the 99th percentile. Currently, the more recently accepted threshold for severe obesity is a BMI greater than or equal to 120% of the 95th BMI percentile. The age at which excess weight gain occurs has important implications for child health and development. Early adiposity rebound is associated with greater adiposity in mid-childhood, which in turn has been associated with accelerated growth, advanced bone age, earlier pubertal transition, and adult obesity. In older children, both overweight and obesity contribute to an increased risk of metabolic syndrome, type 2 diabetes, hypertension, dyslipidemia, non-alcoholic steatohepatitis, and obstructive sleep apnea. There are few epidemiological studies from large healthcare delivery systems examining obesity rates in preschool-aged children. The primary objective of this study was to examine anthropometric findings obtained in clinical practice from a large contemporary cohort of children aged 3 to 5 years to determine the prevalence of obesity and severe obesity and differences by race/ethnicity, sex, and stature, compare estimates using BMI percentile, Z-score, or percentage above the 95th BMI percentile as thresholds for extremely high BMI for age, determine whether children with BMI greater than or equal to the 95th percentile were recognized by their provider, and to review the anthropometric records of individuals whose measured weight and or BMI values were flagged by the CDC Growth Program as being biologically implausible values to determine whether these were actually children with extreme obesity. This study examines data derived from 42,620 3 to 5-year-old children from a retrospective cohort of 160,300 Kaiser Permanente Northern California, or KPNC, children aged 3 to 17 years who had BMI and blood pressure obtained during a well-child visit between the 1st of January 2007 and the 31st of December 2010. The International Review Board at Health Partners Institute for Education and Research approved the study with seating oversight authority by the KPNC Institutional Review Board. The electronic medical records of this cohort were used to obtain information on age, sex, race/ethnicity, and measured height and weight, with BMI calculated as weight, kilograms, divided by height, meters squared. The year 2000 CDC growth charts were used to calculate age and sex-specific BMI, height and weight percentiles, and BMI standard deviation, or Z, scores using publicly available programs provided by the CDC. Three primary methods for data validation were used because of potential errors in height and weight measurements extracted from the electronic medical records. The authors excluded children in whom the height was flagged as a biologically implausible value by the CDC program, and children whose index visit measurement included a height less than 61 centimeters, weight less than 4.5 kilograms, or BMI less than 10 kilograms times meters squared. They also examined growth charts for children flagged with high biologically implausible values for weight and or BMI, and only 14 were found to be erroneous and excluded. Finally, the authors reviewed growth charts for obese children with BMI or height differing by more than 15% or weight by more than 20% per year at a prior or subsequent visit within 2 years. Among the final cohort of 42,559 children, 7,934, or 18.6%, were 3 years old, 23,351, or 54.9%, were 4 years old, and 11,274, or 26.5%, were 5 years old. Half the cohort, at 49%, was female. The cohort studied in this article was racially diverse, consisting of 26.1% white, 5.9% black, 24.4% Hispanic, 21.8% Asian, including Pacific Islander, and 21.8% of other or unknown race/ethnicity. Obesity results. There were 4,775, or 11.2%, children who met the criteria for obesity defined by BMI greater than or equal to the 95th percentile. Overall, and within each of the age stratum, the proportion with BMI greater than or equal to the 95th percentile was slightly but significantly greater for boys than for girls, at 12.4% versus 10% overall. The prevalence of obesity was significantly lower in 4-year-old children, boys 11.7%, girls 9%, compared with 3-year-old children, boys 12.9%, girls 11.2%, and 5-year-old children, boys 13.6%, girls 11%. The prevalence of obesity was highest among Hispanics, boys 18.2%, girls 15.2%, followed by blacks, boys 12.4%, and girls 12.7%. Asian girls tended to have a lower prevalence, 6.9%, compared with white girls, 7.9%, and Asian boys had a higher prevalence, 10.9%, compared with white boys, 8.6%. Severe obesity results. 1.6% of children had BMI 1.2 times the 95th BMI percentile, 1.9% for boys, and 1.4% for girls. Across racial/ethnic subgroups, Hispanic boys had the highest prevalence of severe obesity at 3.3%. Among girls, Hispanic and black girls had the highest prevalence of severe obesity at 2.2 and 1.7%, respectively. Included in this study were 223 children who had BMI and weight percentile values in the 99th to 100th percentile range, BMI z-scores above 2.5, and BMI exceeding 1.2 times the 95th BMI percentile for age and sex. Height results. Among children with BMI less than the 85th percentile, the median height percentile was around the 50th percentile. However, increasing BMI percentile category was associated with an increase in the median height percentile. Increasing proportions of children with BMI at or above the 95th and 97th percentile across increasing height percentile in quintiles. The findings of this study complement data from other studies demonstrating that the prevalence of high BMI for age in older children is greatest among Hispanic boys and black girls. This study found that in the context of routine pediatric care, a relatively high percentage of obese 5-year-old children had their obesity recognized by their clinical caregiver. The proportion of children with subsequent outpatient visits during the ensuing year was also extremely high, suggesting that there are opportunities to initiate preventative measures at this early age. Level of BMI was directly associated with height percentile, consistent with the known interrelationship of BMI and linear growth. Heavier children were taller, and those in the highest BMI category had the tallest stature. This early association between BMI and growth may have important implications for subsequent pubertal development, final adult height, and adult adiposity. One of the challenges associated with assessment of adiposity status during the early years of growth is that changes in BMI represent both changes in adiposity and changes in lean mass. However, calculated BMI is strongly correlated with percent body fat, and differences in BMI at a given height are associated with differences in body fatness. In summary, the high prevalence of early onset obesity is of great concern from a public health perspective because of the strong tracking effect of childhood obesity in relation of childhood obesity to adult metabolic complications and other clinical comorbidities. The early recognition of obesity by healthcare providers and the high proportion with follow-up care within this young age group may provide an important framework to support delivery of effective and timely interventions for obesity management and prevention at an early age. While the population studied in this article was diverse, it is limited by the California region that the cohort was drawn from. Different states within the U.S. likely show different trends in obesity and severe obesity. Also, this study utilizes the CDC growth chart from 2000 to compare against. The recent rightward shift of modern populations adds a manner of variability to the study's results. Additionally, the discussion portion of this study could have been further expanded by explaining how closely linked childhood obesity is to health issues later in life. While this connection is mentioned, further analysis is lacking in the study.